COVID-19 can be characterized as a pandemic.
Cases were mounting in the US. Maybe we might have had 1,000 deaths by then.
We didn't have time. People were dying. The medical community didn't know what treatments to use, and every day counted.
We were inundated in the ED, and the hardest part was sending patients away. It was a lot of chaos, and we were looking for anyone who had strict guidelines or protocols.
When I got diagnosed, when the test came back positive, I was very frightened. There were no known treatments at that point, and people were dying, especially people in my age bracket. I was pretty scared.
It was clear we had to organize our therapeutic effort if we were going to have a chance to come up with something to help people. By late March, I was making phone calls. The first one was to the Foundation for NIH to say, I think we have to catalyze something and it needs to happen urgently.
I was used to communicating with Francis at some odd hours sometimes, but a Saturday call was unusual. Francis asked me directly whether this would not be a good time to put together a public-private partnership with industry, academia, and government to address what was going on.
FNIH immediately agreed, and I called FDA, and everybody said, we can't waste another day.
There was tremendous pressure to authorize various interventions, but the data weren't there. We needed some engines in order to evaluate therapeutics. We needed to crank out data and information.
A huge focus of ACTIV was to provide credible, well-structured, sufficiently powered studies that would generate results in which the scientific community, public health officials, and the American public could have confidence.
And in just 2 weeks, ACTIV was formed with 4 different working groups with participation from what ultimately grew to be 20 pharmaceutical companies.
FNIH, because it's a trusted partner, was able to get people into the room together. You had competitors who normally would be worried about antitrust, all sorts of stuff, who were sharing in a very free manner.
Everybody working 24/7 to try to make something happen, not worrying about who was going to get the credit.
What seemed daunting was the severity of the COVID-19 pandemic and its impact, and the knowledge that we were going to have to do a lot of rigorous science very, very fast. The vaccine situation was already fairly well in hand, but thousands of efforts to test new therapies for COVID-19 were underway.
There was no framework for prioritizing what ultimately was about 800 different therapeutic molecules that people were putting forward. We didn't have clinical trial networks that were all synergized and ready for this. And we didn't have the master protocols so that when you run the trial, you know you're going to get an answer that is convincing and that FDA will say, that settles it.
Nothing had ever been done at this speed, to the best of anyone's knowledge, throughout infectious disease history.
Setting up large-scale clinical evaluation, such as done with ACTIV, is not a trivial task, and the FNIH was a central component of all this.
Our first goal is to come up with a set of rigorous criteria that we would use in order to prioritize those compounds.
We had a group already working with FDA on designing these master protocol trial designs, which allow you to test multiple drugs at once.
The logistical challenges were just tremendous.
It was a step-by-step approach, so we are not losing time and missing, the peak of the pandemic in a specific location, while obviously ensuring that at the end we will have a very diverse population included into the clinical trials.
We were asked to compile a list of any agent that could have been relevant to COVID. There were over 800 in our initial list. By the time we did multiple review cycles, we selected 37 to enter the 11 master protocols, and of those, 6 ended up proving efficacious in some form or another.
Being able to bring that clarity on what works and what doesn't was very important to us.
When more treatment plans came that were based on actual clinical data and trials, it was tremendous for us. because we knew that the treatments that we were using were actually helping.
I went down to UCLA on Friday and received an IV infusion, and I woke up the morning perfect, like nothing had happened, which was quite miraculous as a physician. I was grateful and think that maybe my life was saved by that treatment.
I think what ACTIV program demonstrates is that you really do need a village.
ACTIV was a great example of what can happen when you have a convening authority.
I think the most critical reason for ACTIV's success was a recognition on the part of all participants that our lives depended on achieving a successful result.
These were extraordinary circumstances, and I think ACTIV was an extraordinary response.